Good morning. So I think it only makes sense that after all of my years here, I get to introduce two of my fresh recruits and junior fellows, Dr. Stout and Krieger. Jokes aside, Dr. Stout is a professor of cardiology here, the founder and the long-standing director of the Adult Congenital Heart Disease Service, and the leading author of the new 2018 ACHD guidelines. Dr. Krieger is an associate professor of cardiology here, a reviewer, I'm sure a very critical reviewer of those guidelines, and a member of many of the committees in the ACHD, on the ACHD topics. And so I've been hearing about these guidelines since I was a fellow in 2012. It took them a while to get out there, but I'm sure that this is going to be a fascinating conversation with Dr. Stout and Krieger. Dr. Krieger.
Thank you. Thank you. Can you guys hear me okay? Yeah, okay. We have no relevant disclosures to the talk, so we're going to begin just by a brief outline talking about why you might want to care about adult congenital heart disease. Karen will cover some topics on the guideline process. We'll review what I think is an important classification scheme that was introduced in the guidelines. And then we're going to go back and forth on some of the specific abnormalities and recommendations that were made and try to see whether Karen's recommendations make any sense. So we'll start, of course, talking about why should you worry about something quite as rare as congenital heart disease, and shouldn't we instead be focusing our time on important topics like coronary disease, congestive heart failure, and valvular heart disease. But I'd suggest that adult congenital heart disease isn't quite as rare as many people think. So it's the most common congenital birth defect, and 1% of the babies in the world are born with some form of congenital heart disease. That means in the United States, there's 40,000 babies born each year with some type of congenital heart disease. And while many of these are simple lesions like ASDs, small VSDs, PDAs, a quarter of them have a critical life-threatening defect where if you don't operate during the first year of life, these babies are very likely not to survive the first year. And we've gone through a real rapid progression in terms of how babies with congenital heart disease grow up. So if we think about those 10,000 babies each year who are born with congenital heart disease in the United States, before the 1950s, most of them died in infancy, right? We didn't have surgeries that could treat these babies, and those few that did survive had a markedly shortened lifespan and significant residual defects, cyanosis, pulmonary hypertension, markedly reduced exercise tolerance. And from the 1950s to the 1980s, we entered sort of the second phase of the care of babies with congenital heart disease, where there was rapid improvement in surgical technique, as well as ICU care, diagnostics, the development of echocardiography. And with this, many and even most babies born with complex congenital heart disease survive to adulthood. And now we're in, what we'll call the modern era, but someone will probably look back on in 50 years and call the Stone Age. But death during childhood is now exceedingly rare, even for really complex forms of congenital heart disease. And what that's meant is that there's been a real shift in the survival pattern of babies who are born with congenital heart disease. So I think this figure is a little tough to look at sometimes in terms of not being an intuitive figure, but it's important. On the y-axis is age group, and on the x-axis is the percent of people that died during that age group. The yellow bars represented babies born with congenital heart disease in the 1980s, and the black bars represented the average age of death of the general population. And what you can see is that for babies born with congenital heart disease, complex congenital heart disease, a full quarter of them died during the first year of life, and there was continued ongoing mortality during childhood. And the overall curve is shifted down dramatically compared to the general population shown in black. And if you fast forward just 20 years later, you can see that the demographics change significantly, that death during the first year of life is now very, very rare, and that the overall survival comes close to matching that of the general population. So what does that mean? It means that there's now more adults than children living with congenital heart disease. Back in the 1950s, children outnumbered adults almost 10 to 1, but with improved survival. By the 1980s 1980s, adults had really caught up to children, and for the last decade, there have been more adults with congenital heart disease than children. And this translates into a rapid increase in the number of hospitalizations for adults with congenital heart disease. Looking over this about 9-year period, you can see that there's been a near doubling of the number of hospitalizations for adults with congenital heart disease in the United States, from about 300,000 to about 600,000. So it means you're probably going to be seeing a lot of this over the coming years. So about 2 or 3 years, Karen got together with 2 of our fellows, Katie Benziger, Lisa Zaragoza, and a bunch of math nerds over at the upper campus to try to model how many congenital heart disease patients we were going to be seeing over the next 50 years. So they showed that from the 1970s to 2018, there had been a steady increase in prevalence, and the absolute number of adult congenital heart disease cases, and they modeled that by the year 2060, it was going to continue to increase at an even more rapid rate. So they predict that by the year 2050, there's going to be 600,000 adult congenital heart disease patients in the United States. And that might not seem like a lot when you compare it to the 3 million people currently living with atrial fibrillation. So, maybe not that big a deal. But look at these numbers. Currently, there's 468,000 patients on dialysis, 400,000 with cirrhosis. There have only been 55,000 TAVRs performed and 23,000 LVADs. So we certainly see plenty of those diseases. So 600,000 ACHD patients is probably not a trivial number. The problem is the field of adult congenital heart disease is too small really to care for this population. So the first congenital heart surgery was performed, that says 1938, is that right? That is right. I wrote it. It's a long time ago. It was a PDA ligation. 1954, the first intracardiac surgery was done, which was the repair of Tetralogy of Fallot. And someone, I guess, about 20 years later realized that these kids were actually starting to grow up. So about 20 years after the first congenital heart surgery, the first ACHD program formed in the United States. But it wasn't until 2008 that we had guidelines, in 2015 that the ACGME recognized the importance of a training program and provided board certification for the specialty. And in the year 2018, we're going to have 40,000 babies born with congenital heart disease and 11 training spots in the United States to train new ACHD doctors. So that probably means that we need to somehow disseminate the information on how to care for congenital heart patients beyond what we just tell a congenital heart disease specialist. There's just not enough ACHD docs to keep up with the population. And because of that, 95% of general cardiologists report that they care for at least some ACHD patients in their practice. And less than 10% of ACHD patients have actually ever seen an adult congenital heart disease doctor. And 80% of cardiologists who take care of ACHD patients reported that they looked at the guidelines to try to figure out what they ought to do for these patients. So with that in mind, that's why we need guidelines, and we'll let Karen move on and talk about what she did and why.
What in God's name were you thinking? All right, life is hard. Life is harder when you're stupid. That is how I felt about the guideline process. And so one of the things that we wanted to talk about today a little bit, because as we went through this, I thought there was a lot about the process of developing guidelines that isn't widely known and is actually fairly important. And Catherine's given great talks before on alternative methods for doing the guidelines, particularly around diseases where there's a lot of data. So adult congenital heart disease, we have data. We have more than we did in 2008, but we don't have as much as is necessary to do something like AFib or heart failure or valve disease in terms of making them exclusively data-driven. So I say life is hard, it's harder when you're stupid, because my introduction to any sort of guideline process at all was to chair the committee, never having been on one in any form ever. I would recommend you don't do that if you're given the opportunity. So what ends up happening is you put together a group of really talented, smart individuals who all bring something to the guidelines writing process in terms of expertise. And the guidelines are shepherded along by me and my co-chair, my vice chair, but is really the work of that group of people. So in selecting that group of people, you're picking expertise, you're picking people who are going to do the work and get things done, and this group was really amazing. But what's the actual process? It is not necessarily an intuitive one. These are experts who do this all day, every day, which is actually what you want, but it also means they're walking into this process with a lot of preconceived ideas of what the right thing to do actually is. So the process, which is devised from the Institute of Medicine processes, is to first convene a writing group committee, and the whole relation with industry thing becomes a really big deal. And the only thing I'll throw out about that is in big fields, it is probably relatively easy to get a bunch of people who have no relations with industry who are nonetheless expert in their field. When you have small fields, the people who are the experts are the ones often doing the research. And if it's a small field, the research is not paid for by the NIH. It's paid for by industry. And so finding that balance can be really tricky. And so the entire system is built around making sure that those relationships are balanced. It is a problem when the process takes a really long time and people accrue other research grants and that sort of thing. So I would just say it's easy to cast aspersions for the whole so-and-so is on the speaker board for 95 different companies, which is probably a pretty good balance. But it doesn't necessarily mean that everything they've written is in some way tainted, despite sometimes the processes that seem like it is. So you're trying to look for medication influences, industry influences, but you also have to be really careful about the influences. And as the chair, your task is to balance the intellectual biases that people bring that have nothing to do with Novartis and everything to do that they want to cath everything that walks. And so my interventional cardiologists on that committee and my surgeons, that was a good time to watch the duking out of which way is better to close an ASD. So you kind of have to balance some of those. So as we did that, actually the group was amazing because it was a group that really respected one another's expertise and was able to have really cogent conversations about what we should recommend when there is or isn't data and making sure that we were respecting all of the potential ways to do things that had validity. So there's an outline, you assign authors and do that sort of thing. Then you have to do this deep dive into the data. And for adult congenital heart disease, our biggest randomized controlled trial has 88 people in it. Yeah, yes. But that data still has to be the deep dive, and each individual author has to do that before coming up with any recommendations, which for people who've already decided they think they know what they're doing is a really interesting exercise. And then they get put into data supplements, something like 300 pages of data supplements. If you're really struggling to sleep, I would recommend Ambien's probably not near as good as going through some of our data supplements. So please feel free to use that as a sleep aid whenever you need to. There's also the language used to make the recommendations, which everybody gets really accustomed to. But for anybody who's worked to do this, it kind of forces you to use English in a way that you're not necessarily accustomed to. Because when you make just casual statements like, oh yeah, I think that would be a really reasonable thing to do, that carries certain weight in terms of recommendations. So you have to be pretty careful about the language. And then there's a very specific thing that we're going to come back to up there. If you look at what a class 2A recommendation is, I had learned as a fellow from Catherine that a class 1 recommendation was the thing that everybody in the room agreed on. A 2A was the thing that everybody in the room agreed on except that one guy. A 2B was the thing that that one guy thought was a really good idea, but nobody else agreed on. And then you went from there. So the current strategy from this is that benefit versus risk is a lot of what drives a 1, a 2A, a 2B in terms of the class of recommendation. And then the level of evidence is how many randomized controlled trials do you actually have to support your recommendations. And the general effort is that you want to do as few expert opinion recommendations as you can and really rely as much as possible on the actual data. So then we make the recommendations, and in this case, you have to really make sure that one voice doesn't dominate all the others. So that you don't have the surgeon saying, oh my God, you can't do that with a catheter, and the catheterizers, Rob knows Jamil well, Jamil saying, I can do that. Well, okay, fine, you can do that, but that doesn't mean we make it a recommendation. So you have to really balance people's opinions. There's group meetings, endless conference calls, yada, yada. You finalize the document. They set it up for 15 months, which is why it took 4 years. And then you send it off for review. And I think a really important distinction that I'm going to get to is the review process for things that are actually labeled guidelines. Really important to distinguish guidelines from other documents that have recommendations in them. And I'll show you that in a second. Is the review process is reasonably brutal. In this case, there's a lot of reviewers, 46 of them, which doesn't seem like many, except that they generated over 3,000 comments. Each of them I or Kurt, my co-chair, had to specifically address, either change or at least reply to. And that was extraordinarily valuable. These things are unbelievably vetted. They are vetted from people's particular lenses and expertise, which is incredibly helpful. And then you finally go through the whole document, you send it off to the 8 committees, the surgeons come back literally at the last minute with some objection about an entire section that they had opportunity to look at before, and then you have to talk them through why you said what you said. So there's a lot of opportunity for vetting. And ultimately then the thing finally gets published electronically and then in print. So level of evidence, we really are trying to balance high quality data. That, by the way, just looks like a terrible idea. Uber in a land with no cars is apparently that. And then really trying to minimize the limited data thing. And it is really easy, as we're going to get to just hone in on the recommendation. But one thing I'll say is, as we were writing these, because we have this very big population where that balance of leaving people with nothing versus expert opinion is really a delicate walk. And so we tried to do that whenever we could. If there really wasn't anything useful to say, we didn't say it. But rather than leave people to make it up on their own, we often would actually make recommendations, even in the absence of data, that was based on expert opinion. But we really try hard not to stifle innovation. Krieger has said on any number of occasions in conferences, well, I can't give my Fontan patients a DOAC because you told me I can't in the guidelines. And that is not how we intended it, I swear. In this particular thing, it says we cannot be recommended, but it doesn't say you can't do it. If we actually meant you can't do it, we'd make it a class 3 recommendation, and you couldn't do it. So when you look at the text, definitely read through the entire thing, because often the opportunities for innovation are embedded in the text. And one of our writing committee members in particular was exceedingly good at saying, look, you make a recommendation on this now, and nobody's actually going to answer the question, because they'll assume it's been answered. So we tried really hard not to stifle innovation. So how did we do with all of this? 175 pages of the edited version, 179 recommendations, a ton of data supplements, 90 level of evidence C. So those are the expert opinion. 88 level of evidence B. 1 level of evidence A. This was a huge thing for our field to actually have randomized controlled data on one thing, which happens to be Eisenmenger syndrome, which is psychotically rare, but there you have it. We had one and we were proud. So the thing that was good about this is that the field has really progressed in such a way that the prior iteration of these was vastly more heavily expert opinion. And in the last 10 years, a lot of data actually has been generated that allowed us to do a lot of level of evidence B recommendations. So a key difference that I'll come back to is, again, just jump in and be a chair on things rather than being on the writing committee to figure out what's going on first. I chaired a pair of what turned into a pair of heart failure documents on congenital heart disease. And that's an AHA document that was initially set up with the intent that it was going to make recommendations. And then once we all understood the difference in processes between the one on the right and the one on the left, we didn't make any recommendations in that document because the reviewers, 3 reviewers for a scientific statement, period. Not vetted by other societies. And the 3 reviewers are just saying, hey, it's a great job. So we didn't feel comfortable making recommendations with a process that was different and a vetting that was different. So as you're reading things that have recommendations, they're always a good thing to have out there. But I thought it was a really valuable thing to understand the distinction between a guideline and what goes into it and some of the other documents that we rely on, and then understanding some of the differences between the two. They all have validity, but they're definitely vetted from different places. And then the other thing we were really trying to consider is who's the audience? AFib, TAVR, whatever, a lot of those are really honed in on particular audiences. And the funky thing that Eric was alluding to with adult congenital heart disease is a ton of people touch on it. So if we kind of go back to the original idea in med school that if you hear hoof prints or hoof beats, it's horses. If you hear hoof prints, you should quit taking whatever it is you're taking. But If you hear hoofbeats, it's horses. And there's always those things where, yeah, they could be the more rare thing of the zebra that you're actually considering. And then what we're hoping is that ACHD, certainly in this place, is something a little bit more familiar. That's a Horbra or a Zorse, whatever you'd like to call it. It's sort of a hybrid of something that seems really familiar with something that is less common. So our audience has to cover the spectrum of people who perceive ACHD as a horse to those who perceive it as a completely sparkly, multicolored zebra. So that's my friend Jim. Jim is an orthopedic surgeon at Children's, or at Swedish, and his touch on adult congenital heart disease is never, unless we're at dinner and it happens to come up. But he's nonetheless somebody that the guidelines actually have to speak to were he to encounter a tetralogy patient whose knee he's going to replace. So we had to kind of make sure that that audience was spoken to by what we said, and that people like Kim O'Connor, Edith Chang, and Kelly Branch, who get tortured with these patients in various iterations, Kelly on the inpatient service, Edith in OB, and Kim over in general medicine at Roosevelt, that they had something that they could refer to that would help them care for patients. Mark Lewin, the chair or the chief of cardiology at Children's. Melissa, who gets to take so many of our patients to the EP lab. We actually had to write guidelines that helped the people who wrote the last set of guidelines. And hardest of all, that Yahoo. So when we're looking at the guidelines, we actually put a lot of effort in trying to figure out who's our audience. Everybody's going to touch these patients. We really want the patients to get the best care possible. Which recommendations are going to help that spectrum of people? And so with that, we'll hand back over to the Yahoo we were trying to please and discover whether or not that worked.
Real well.
Yeah.
Okay. Thanks, Karen. So going back to our point before that we need these guidelines because there's not enough ACHD doctors to take care of the patients. But the truth is that patients, particularly complex patients who get ACHD care at ACHD centers, seem to have better outcomes. Here's a study looking at over 71,000 patients in Canada, depending on whether they got their ACHD care at specialized referral centers or non-specialized referral centers. And of course, this was a population-based study, nothing randomized, of course, but they did detect some type of mortality benefit to complex ACHD patients getting care at ACHD centers. But of course, this just was limited to patients with more complex disease. So it'd be pretty reasonable to say that the complex patients should be referred to ACHD centers. And for the last couple decades, most people have used the same schema to break patients down with congenital heart disease into simple, moderate complexity, and great complexity state. And it's all based on anatomy up until now. Simple diseases are things that you would think are pretty simple, like a bicuspid valve, sorry, Catherine, a small PFO or ASD, a small VSD, or a repaired PDA. Things that are moderate complexity are a little more complicated, like coarctation, anomalous veins, AV septal defects, tetralogy, etc. And then the things that we classified as complex are complex, conduits, Eisenmengers, Fontans, etc. But the problem is that that doesn't really capture the complexity of an individual patient. So let's start with something that's listed as simple, bicuspid valve. And there's really a spectrum of disease severity within any given anatomic diagnosis. So I think we'd all agree that a 47-year-old woman with mild aortic regurgitation, normally functioning ventricle, and a normal aorta, and a bicuspid valve is simple. We don't think that patient should travel across the state to an ACHD center. A 53-year-old man with moderate stenosis of a bicuspid valve, hypertension, and aortic aneurysm probably is more complicated than the woman on the left. And then you could have a 20-year-old woman, severe AS, mechanical aortic valve, a large aortic aneurysm, who shows up pregnant. And I think we would all say, despite the fact that these three patients have the same anatomic diagnosis, they don't have the same disease complexity. And prior classification schemes didn't really capture that. So one important thing that was introduced in the new 2018 guidelines that I think is going to have an impact on how care is delivered, but also how patients are categorized for research, is the introduction of this new anatomic and physiologic classification of disease. And in the new guideline statements, patients are broken into a certain degree of congenital heart disease anatomic complexity, but also a physiologic state. So the anatomic complexity they use mirrors very much what has been previously used, simple, moderate, and great complexity, and you can see some examples on the left side of the screen, although it's not comprehensive. But then we have physiologic state based on the patient's state of wellness. It somewhat mirrors New York Heart Association functional class, but also takes into account issues like residual shunt, residual arrhythmia, exercise performance, and residual cyanotic lesions. So now patients are broken up not just into disease complexity, but also the physiologic state. And I think that's appropriate because not one size fits all. So you could have two Tetralogy of Fallot patients, one maybe who had an incomplete repair and persistent cyanosis, New York Heart Association class 3 and refractory arrhythmias, and that patient does not have the same disease complexity as Sean White, who also has Tetralogy of Fallot and has won 3 Olympic gold medals and 10 ESPY awards for the best male action sports athlete. And the guidelines, therefore, don't recommend that these patients get the same intensity or frequency of follow-up. So here's an example of what the new guidelines recommend for follow-up in patients with Tetralogy of Fallot. They list a number of different types of follow-up, clinical follow-up, ECGs, echoes, oximetry, MRIs, etc. And then for any given anatomic diagnosis, they recommend a different intensity of care depending on the patient's physiologic state. And I think there's a hope, although it certainly hasn't come yet, that insurers will recognize that there's recommendations out there, for example, how often we should be echoing or MRIing these patients, and perhaps there'll be some more encouragement for people to cover testing depending on a patient's physiologic state, and we'll have something concrete we can turn to. So with that in mind, let's go on to a couple of the specific lesions that are covered in this document. Of course, this isn't going to be comprehensive, but just sort of pick apart some of the recommendations that they made and see whether they make sense. So everyone in this room remembers Tetralogy of Fallot, 4 things, right ventricular outflow tract obstruction, VSD, and overriding aorta, and then compensatory right ventricular hypertrophy. And we remember that most babies with Tetralogy of Fallot are now repaired in about the first year of life. But like with most forms of congenital heart disease, the repair is not curative, right? So we do a repair that usually, particularly in prior eras, consisted of a transannular incision, leaving patients with severe pulmonary regurgitation, right ventricular dilation, and right ventricular dysfunction. And then we put a VSD patch and an RVOT patch on there, which predisposes patients to ventricular arrhythmia. So we've made these patients better, but we certainly haven't cured them. And one of the core questions in congenital heart disease that we try to answer most often is what's the right timing for pulmonary valve replacement in patients with Tetralogy of Fallot? Anyone who's done our ACHD clinic will agree that that's probably 25% of the patients we see in the decision we have to make. And really it comes down to a question of how long can we wait to replace a pulmonary valve? And another way of saying that is after which point will a patient have irreversible and permanent right ventricular enlargement or dysfunction? And the idea is that we'd want to replace a valve before that. And for years and years and years, everyone's tried to answer this question using the same research methodology. What they do is they start by saying, what's an optimal outcome? An optimal outcome is an RV that's a normal size and works normally after surgery. So they might say that an optimal outcome means that after surgery, we end up below the green line with an RV EDV of, let's say, less than 100 mL per meter squared and a normal right ventricular ejection fraction. And then let's go back and look. If we want to end up below the green line, where do we need to start? Well, we need to start before this other green line. So we can wait up until patients get to an RV EDV of 160, 170, 180 mL per meter squared, depending on the study, and we should operate then. And, you can do an ROC curve to try to determine the optimal cut point for when you ought to replace a pulmonary valve to end up with an optimal outcome. And a number of studies have done this same thing. But I think there's pros and cons to early intervention versus late intervention. Early pulmonary valve replacement preserves RV function and allows you to normalize RV size. But of course, waiting to do a PVR has its value too, because when you put in a prosthetic valve, these patients have an increased risk for endocarditis. If you put in a prosthetic valve early, these patients wear out their valves sooner than they otherwise would have. And of course, while our surgeons here are amazing, I mean, the truth of the matter is when you go for an open heart surgery, there is some surgical risk. Some small percent of these patients will die in the operating room or during the postoperative time. So trying to delay exposure to surgical risk has some values. So when you ought to replace a pulmonary valve seems like a great question for a randomized trial, randomize one group to early intensive therapy and early valve replacement and one group to late valve replacement, but it's not practical with the number of ACHD patients that we have and the difficulty enrolling patients into randomized surgical trials. We're probably unlikely to power a question that way. So what do the guidelines say? The guidelines recommend that if you have significant pulmonary regurgitation and you're symptomatic, you should get a pulmonary valve replacement. That's the first branch point. And that matches what we do for almost all valve disease. Symptomatic valve disease gets intervened on. But then this flowchart gets a little weird. They say that you need two of the following things. You need to have RV dysfunction, RV dilation, RV pressure overload, reduction in exercise tolerance, and any two of those, not just have a big RV. And if you have two of those, you can get a pulmonary valve replacement. If not, do you have sustained arrhythmias? If so, you now have a 2B recommendation for a valve replacement. But if you don't have that, even if you have a big right ventricle, the way this flow chart looks, it suggests that you'd have to follow up with an ACHD cardiologist, and there's no recommendation made for a pulmonary valve replacement. So Karen, these guidelines are not, generally speaking, how most ACHD doctors practice the management of Tetralogy of Fallot. Most of us send patients just for big RV. So why don't your guidelines match what most of us do in practice? That's my nicest one.
It is totally his nicest one. Okay, so while vacationing in Africa, Pinocchio has his longtime wish to be a real boy, suddenly and unexpectedly granted. Be careful what you wish for. We wished for data to reinforce what we do all the time. So we have the data. It doesn't reinforce what we do all the time, which is where the guidelines can run a little aside of clinical practice. So what do we know? We know that right ventricles beyond a certain size are less likely to normalize after pulmonary valve replacement, and there is clearly a circumstance where too big is a really bad thing and smaller is better. So we know that. And we actually have a ton of studies that give you a sense of what the data would suggest those size should be, whether it's end diastolic or end systolic volumes. We also know that PVR, and this is a randomized or a meta-analysis that was done of all of the various trials out there, and it actually improves RV size, RVEF, which is what you'd hope, but it also does improve New York Heart Association class. So people who are symptomatic or have a diminished exercise capacity will be better after you replace their pulmonary valve if their pulmonary valve is the problem. PVR, though, as Eric alluded to, has a mortality risk. And let's go back to that whole 2A1, 2A, 2B thing of benefit greater than risk. So if PVR, surgical PVR, and actually any PVR, even melody valves, carry with them in the trials some mortality risk, even though low. If you actually have a mortality risk, then you really need to have a mortality benefit. And we just simply haven't demonstrated that. And so when you're trying to look at who is most going to benefit from a pulmonary valve replacement, it's going to be symptomatic patients and then this sort of aggregate of the other things that we see. And Grumpy Cat is really reasonably annoyed, as I was, that we didn't have a clear-cut, yes, pulmonary valve replacement is a slam dunk, you should just do it, we're making patients better, because we all believe we are. Making patients better, that is. This is a circumstance where in preparing this talk, despite 40-some-odd reviewers, 3,000 comments, and 4 years, the difference between that flowchart and the actual recommendation is relatively striking, which we're working on fixing. So the recommendation that's written there actually does allow for replacing the valve based solely on improving right ventricular size. What the text says is what's in that box, which is in the absence of mortality data, the patients who are most likely to benefit from this are those who have 2 or more of those things. So trying to allow people yes, this is what the data shows, but the reality of how you practice allows you some nuance patient to patient of who's actually going to get benefit. And one of the things we're having to do now, having an electronic version and a soon-to-be print version, goes back to the power of punctuation. Eric and I have been having a big debate about the Oxford comma. My mother she has a t-shirt of this. Let's eat, Grandma. Let's eat, Grandma. So the asterisk in this case is being added to that flowchart so that people who look at the flowcharts don't stop there. And they actually go back to the recommendation to understand the mortality benefit has not been demonstrated, but it'll end up, these are the patients who are most likely to benefit. And we're trying to, again, give people some guidance on how to manage something where there is some data, but not an abundance of data. And one of the things that reviewers, Krieger, said several times was, well, what about AR? Why is PR so different? And the reality is it actually isn't all that different. The one thing, though, that the valve guidelines had was they actually have a lot more data and a lot more track record of interventional impact. And nonetheless, though, when you look at it, symptoms, EFs that are down, most of the indications here are very similar. But when I read Catherine's guidelines compared to ours, there's just a longer track record of data on the result of intervention. So that actually is reflected in our guidelines, which include that various hodgepodge of different things as options. So the other thing that's really important to remember about these patients is that they're young. And we come back to that. These are young patients. This isn't a one and done. So what's the impact of multiple sternotomies over a lifetime? So if you're talking about initial repair and then all these valve replacements, you're looking at multiple sternotomies in somebody's life if we succeed in getting them a life expectancy that's typical for the population. So if we do that, that has to be balanced into this, which is why that diagram has a lot of the in addition to thing. What about transcatheter pulmonary valves? We think that is going to be a game changer and that that'll favor early PVR provided the endocarditis risk doesn't turn out to be excessive because it should cut down on what we believe to be the higher risk endeavor, which is the repeated sternotomy. The fact of the matter is we haven't proven that yet. We've proven transcatheter PVRs work, but we haven't proven that that strategy that we all believe is actually there yet. So it can't actually be reflected yet in the guidelines. But it is an awesome opportunity to reflect back on how these things are made now and why we had to do the entire guideline over again, which is a modular format that allows individual things to be updated in more real time. So the minute we get data that supports that, you can go back and replace just that one recommendation and influence practice in that regard. So that's why.
I have a question.
Can we hold the question till the end? Is that okay?
Sure.
Thank you, Karen.
All right, let's move on to ASDs. So ASDs, we're all aware, cause a left-to-right shunt that leads to right atrial right ventricular enlargement, pulmonary overcirculation, and undercirculation of the systemic circulation, which causes patients to have exercise intolerance. And unrepaired ASDs lead to atrial arrhythmias, and about 10% of patients with large unrepaired ASDs might develop pulmonary arterial hypertension. Maybe not quite that many, but some percent. And ASD repair, both surgical or with a catheter, can be performed with less than 1% mortality and a really low rate of late complications. So we can close ASDs safely and effectively. And closure of ASD works to improve RV size, pulmonary pressures, RV function, and symptoms. So here's a study of 236 patients with an ASD. Baseline QPQS was 2.2. They looked at 3 different age groups, age less than 40 in green, age 40 to 60 in orange, and age greater than 60 in red. And on the left panel, you can see that the RV size gets smaller in all age groups once you close an ASD. That PA pressures get smaller in all age groups, particularly in younger patients in the middle panel, and that patients feel better on the right panel. Patients, this is pre and post for each of the 3 age groups, green being New York Heart Association Functional Class 1, and once you close an ASD, you have more patients in New York Heart Association Functional Class 1. So ASD closure works. In addition, ASD closure is supported by a large randomized clinical trial. This is a randomized trial of 521 patients randomized to surgical ASD closure and medical therapy. These were older patients for congenital world, average age of 50, 25% with pre-existing arrhythmias, normal LV function, a 2.5 to 1 shunt, and a mildly elevated PVR. There was a number of crossover and dropout, but they still had over 150 in each group at the end of analysis. And the primary endpoint of a composite endpoint was improved in patients who went for a surgical ASD closure. Now, mortality was no different, but it was driven by less sudden death for some reason and less pneumonia for some reason, which I think is why this trial hasn't caught on quite so much, is because the endpoints don't really quite match what we'd expect in our clinical practice. So, seeing that as the wealth of information, what would you recommend for a patient with an ASD? Since it can be done safely and effectively, it improves size, function, symptoms, and composite endpoints. And the 2008 guideline authors looked at all of that and said, wow, that is compelling information. We should give a class 1 level of evidence B recommendation to closure of an ASD, either percutaneously or surgically, for patients with RV and RA enlargement. This is simple. This is intuitive. This is what we all do. And then Smarty Pants over here comes along in 2018 and decides that, in fact, it's not simple, straightforward, and maybe this isn't what we should do, and comes up with some godforsaken mishmash of recommendations that are too small to read. But there's no class 1 indication for ASD closure in patients with right heart enlargement. So, Karen, how did you come to that conclusion? And I will note that you still did leave a class 1 recommendation for closure of a VSD or a PDA in patients with left heart enlargement. So why have you chosen to punish Zachary, Steinberg, Mark Reisman, Tom Jones, and prohibit us from closing ASDs?
So if you cherry pick your data, you can kind of do whatever you want. Krieger. The thing that's really cool about these guidelines, there's a couple things that are cool. Get me going and I'll tell you the couple things that aren't. But one of the cool things is that going along with the Institute of Medicine, they have you do things that are evidence review committees. And so we came up with 3 questions to ask for evidence review committees. One of them was the timing of pulmonary valve replacement, but then a meta-analysis came out that essentially obviated the need to do that. So we as the guidelines committee say, what are super important questions that we need a deep dive, systematic review, meta-analysis done by a totally separate group that is firewalled from us. And so we had 2 different questions. One, which we're not specifically touching on today, but to emphasize for anybody who knew Elisa Zaragoza, one of our former ACHD fellows, she's the lead author of this particular evidence review committee that looked at medical therapy for systemic right ventricles, and found after many, many, many pages that we just don't have enough data to say anything one way or the other. We also did one, though, for ASDs. And really the important thing, this goes back to be a little careful what we ask for, is when this group, who are very good at doing this, and are experts in the field, did their evidence review, they came back with everything Eric just said. It makes patients feel better. So if they are symptomatic, you should close their ASD. But they did not find a mortality benefit, and he alluded to that as well. And so we go back to the constraints that were put on in writing guidelines, where risk has to outweigh, or has to be outweighed by benefit. And when we don't have a mortality benefit, you have to walk a little carefully on slam dunk saying you must do everything. And a lot of the data that was used, actually, much of it was generated in the last 10 years, which then also means that there's going to be a difference between the 2 guidelines 2008 to 2018. And it's not just because I'm more wordy that we actually did it. When you look at VSDs and ASDs, they're not the same thing. A left heart load is different than a right heart load. We're not trying to punish the right ventricle, even though it seems that way sometimes. LVs are different. There's data behind that. And the morbidity and mortality data for these 2 things actually are reasonably different. There's a little bit more data out there that there's a mortality and morbidity benefit to VSD PDA closure at a different threshold than we would for ASDs. And back to Krieger's thing, though, like if they're symptomatic, he showed that data. If you're a New York Heart Association Class 2, you got better. It doesn't say how many of the New York Heart Association Class 1s felt better because they were asymptomatic to start with, presumably. So that patient population, you wander a little bit more carefully into saying we're going to close this and to what benefit. But you still can. Like Kriegs was super happy with this one. It's not that we said you couldn't, it's just that it's a more nuanced conversation with the patients regarding what the potential benefit is. So every time we come up with something that isn't necessarily a class 1, the 2A's are what's supported by data, and when we want to change it, we just get more data. That actually did make, grumpy people grumpy. But it really goes back to the idea that if you like Pirates of the Caribbean, these are really more what you'd call guidelines than actual rules. And they really are guidelines, and when you look at the text, we try to provide some of the nuance, not to say it's the wrong thing to do, because when we think something's the wrong thing to do, we say so. And there are very few of those. But to kind of give people a sense of, if you're sitting there individually navigating a patient, here's how you should approach the data as we currently know it, and when we know more, we can go back and revise those recommendations. So you want to close them in, everybody, then you go prove it, my friend.
Thank you.
Yeah.
All right, moving on to anomalous coronaries. Okay, so what do we know about anomalous coronaries? We know that they're relatively rare, and anomalous aortic origin of the coronary arteries maybe 1 in 1,000 patients, but they're responsible for up to 10% of the sudden death in athletes. We know right from the left is more common than left from the right. That being said, 85% of the patients that die with a left off the right. So therefore, we think a left off the right is the more lethal coronary. We know death typically happens during high-intensity sports and that young people are at higher risk. But there's a lot we don't know. We don't know why they die suddenly. We don't know who's going to die. We don't know what tests are useful to predict death. We don't know whether we should exercise restrict the patients that we choose not to operate on. We don't know whether chest pain is a bad sign in these patients. And we don't know whether we should fix all coronary anomalies. So, what should we do with my patient with an anomalous coronary artery? So let me tell you how it happens in real life. You're sent a 20-year-old patient with a murmur for evaluation, and you listen to the patient and you go, that sounds like a flow murmur. This patient is fine. But maybe I'll just get an echo just to be sure. And then God punishes you by showing you an anomalous right coronary from the left sinus with an interarterial course. This happens,
Entirely too often.
Entirely too often. So what do you do? What do you do? You could decide that you're going to read the tea leaves and say, it's not that acute an angle of takeoff, and the orifice is a little slit-like, but not that slit-like. I think this patient's kind of not super high risk. I guess you could do that, but you'd have to recognize you're sort of making it up. You could look at the patient and be like, dude, I don't know. I guess we could fix it. I guess we couldn't. And what do you want to do? How about stress testing? Stress testing seems like a good idea to risk stratify patients, but the problem is that they're only validated in atherosclerotic coronary disease. Sudden death, unlike angina, is unpredictable. Patients will exercise 10,000 times and then drop dead the 10,001st time. Most importantly, stress tests don't seem to really work in patients with an anomalous coronary. There's a lot of false positives and a lot of false negatives. Just 2 quick examples. Here's 27 patients with an anomalous aortic origin in their coronary artery who died. Okay? On 12 of those patients, they had clinical data. 10 of them had symptoms, 2 were asymptomatic. 12 of them had ECGs, they were all normal. 6 of those patients had stress tests. They were all normal. And then those patients died. 24 patients had stress tests before and after surgery for an anomalous coronary. Preoperatively, 24 patients, preoperatively 16 of them had stress tests, and more than half of them were abnormal. Great. Well, these 24 patients got operated on. Surgery was thought to be a success. And then after surgery, more than a third of them still had an abnormal stress test. And 1/3 of those stress tests showed an abnormality in a coronary distribution that had nothing to do with the anomalous coronary. Not very confidence-inspiring. So sometimes life gives you lemons. The data's a mess. You don't know what to do. What do you do when life gives you lemons? Karen makes recommendations. So the guidelines recommend stress testing despite a lack of evidence. If we look at the flow chart, we don't have to read the whole thing, but first you decide whether they have a right off the left or a left off the right, and then regardless of which, the flow chart suggests that you look for symptoms or do a stress test on the patient and then base your treatment decisions based on the result of the stress test. Now, Karen pointed out that they were very careful to do an evidence review committee for some of these important questions like ASDs and medical therapy. in patients with a systemic right ventricle, which is great. But if you're so careful to do that, why did something so shaky, like recommending stress tests in patients with an anomalous coronary, make it into a recommendation in the guidelines?
So there's a couple of things on this one that are really interesting. First is, there actually is more data. Obviously, Eric's constrained by some time. And the data can allow you to interpret things a bit differently. So here's one where we were faced with a choice. We can either make recommendations which had been done in 2008, so they already existed in the ACHD guidelines. So we either remove them entirely and leave a blank page so that people go back to, I don't know, I don't have any guidance. Or you take a group of people who actually have some expertise in this, and you ask them to take the Rosetta Stone of the available data and translate it into something that might actually be useful. So this is sort of a summary that's in the guidelines of the available data. And one of the things that's super important is the specific interpretation of the value of exercise testing. The study Eric just showed, you noticed, was exercise ECGs. It was not imaging in any form. There is ample data that patients who die suddenly have fibrosis. The vast majority of them have fibrosis in the distribution of the coronary artery in question, provided they are under the age of 35 and don't have concomitant coronary artery disease. So in looking at the entirety of the data, we were kind of a little stuck in this particular spot, but nonetheless felt that we could make recommendations, not so much that an exercise test is protective, but if you have ischemia in the distribution of the anomalous coronary, that there is reason to consider fixing it. So it still allows for the nuance of, you can do the exercise test, and if it's completely normal, what are you going to do with it? We didn't answer that question because we can't answer that question, except that we did do something differently than has been done before, which is that we actually, and this freaked out the ACC and AHA, we have two opposing recommendations with the same level of evidence and the same, because we were like, yeah, if it's an anomalous right off the left and blah, 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 you could go either way. We don't have data one way or the other, but we needed to be able to give people the latitude to do continued observation. And that's how we came up with doing that. So I actually found not only the process of the guidelines and the reviewers, and there's several of them in this room, to be extraordinarily educational. Going through this process with Kriegs has been extraordinarily educational. But I think there's also value in remembering that this is still a funky specialty. And there's Chris. So Chris, 35-year-old, transposition of the great arteries, treated with a mustard repair, subjectively normal exercise capacity, rode his bike to his clinic visit, which is relevant only because he lives in Albuquerque. So our mustard patient rode his bike 1,500 miles over 10 days with a little cart behind him to come visit us, where we promptly did a CPAT on him, which one could argue was kind of ridiculous, but there we go, we did it. Which he did okay, but not spectacular. But this dude has a systemic right ventricle. There's never going to be a guideline to help us with the stuff that patients do on a day-to-day basis. In fact, thank heavens he asked for forgiveness rather than permission, because God knows what we would have been able to say to this guy. But we kind of felt like, we're going to try to answer as many of the questions as we can be helpful with. But the reality is there's a ton of things out there that patients get into, or clinical circumstances where the guidelines are truly that, guidelines. And you're going to have to nuance everything else. So we tried to cover what we could. We tried to take the feedback that we got. And then we put these things out there and are getting feedback back. And they can be modified. So please go out, change the field, learn new things, help us influence the guidelines. And then in the meantime, this is the end of the particular talk, and we really want to thank you because this was way cheaper than therapy.